Good afternoon, everyone. Can you hear me?
Yes.
Yes, we can.
Wonderful. Hi, I recognize some voices there. Hi, Dr. Balmer. Hi, Dr. Chen. Hi, Dr. Brooks, Dr. Hufford. A lot of our wonderful leadership from across the state, Dr. Jambroni, and we have a lot of new people joining us as well. I see that out of the 140 or so that are signed up, we currently have 44 signed on right now.
Hi, everybody. Rishi Manchanda here.
Nice to meet you, Dr. Manchanda.
Likewise. Sorry for the delay.
So staff, would you please turn to the thank you slide? Thank you. And we will start right at noon. I'm going to give people a minute or so to sign in. And Dr. Brooks, I'm not seeing your video. Could you please turn your video on?
Certainly.
Nice, thank you. If our leadership would please turn their videos on, if they're able to do so, I'd love to have you acknowledged. And thank you so much to our speakers for joining us on this important, very important session about expanding the care team. For those of you who don't know me, my name is Hattie Hanley, and I'm the co-founder and founding director of the Right Care Initiative, which is a collaborative project across many wonderful institutions, including most of the UCs, and we are housed at UC Berkeley School of Public Health in the Center for Healthcare Outcomes and Innovation Research. We have been driving goals that reduce disability and death, which have been found to be very effective. So behind my head, you see slides of how quickly you can drive down acute myocardial infarction hospitalizations by getting patients optimized for cholesterol, blood pressure, and blood sugar. Those three metrics have been the core of the Right Care Initiative now for 14 years. This is a collaborative between the major academic institutions across California, State of California Department of Public Health, many private corporations, and leadership from across the health systems of California. I want to particularly acknowledge the assistance from the University of Southern California and the School of Pharmacy there for helping to provide leadership on the important topic of pharmacists on the care team. And I want to thank cardiologists from around the medical centers of California, as well as medical directors. And our sponsors include the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the Stroke Awareness Foundation, the Tennis Getter family, the Dupereau family, the University of California, San Francisco, the Health Trust of Santa Clara, Johnson & Johnson, Novartis, Genentech, Amarin, Amgen, Boehringer Ingelheim, UC Davis Cardiology, UCLA Cardiology, and I could go on, but I don't want to take up the whole meeting doing that. So let's go to the first slide, please. So most of you know me by now, and I have been working on this actually since I was in graduate school, which I completed in 1991 at the Kennedy School of Government at Harvard. And I actually started this project from my desk at the California Department of Managed Healthcare. And when I realized how poorly those three metrics of controlling cholesterol, blood pressure, and blood sugar were met, I rang the alarm bell, looking at the performance data that's provided by the National Committee for Quality Assurance and the California Office of the Patient Advocate in collaboration with many entities around the state who've agreed to share performance data. Next slide, please. So as I've mentioned, we derive blood pressure, blood sugar, cholesterol, and it works, it matters. Our work has been associated in our first in-depth pilot with a reduction of 3,826 fewer acute myocardial infarctions than anticipated, as well as savings of $86 million in San Diego, where we were able to provide intensive treatment on the formula in the next slide, please. So it may seem simplistic, and many of you already know this, but this is a synthesis of things that we have found to be effective across the high-performing health systems of California and beyond. So one of the most powerful interventions, the most muscular, is really adding a pharmacist to the care team, using protocols, working under collaborative orders with a broad team, which increasingly we're learning must include the community health worker. So with that, I would like to turn the meeting over to our Los Angeles co-chair, Dr. Oliver Brooks, who is the immediate past president of the National Medical Association, as well as the chief medical officer of Watts Healthcare and LA Care. I'm not reading, I'm just memorizing. So Dr. Oliver Brooks has been part of the Right Care Initiative since January 2018. I remember when he joined us, and I was just so excited when Keith Emmons brought you into our group, Dr. Brooks. So with that, I'd like to hand the meeting over to you to facilitate. Thank you so much for your willingness to lead.
All right, thank you very much, Hattie, Ms. Henley. Thank you for your 14 years of effort in this area. I think it's important to understand something that she said. It may seem simple, but it actually is simple. But if you control cholesterol, blood pressure, and blood sugar, you will get the results that you desire. I think it's really important to understand that because it makes things concrete. These are the actions that we need to take. And then all of the discussions that we have today and at other Right Care initiatives ultimately are focused on those areas. Reduce stroke, heart attack, cardiovascular incidents, and she spoke to it well. So when we are in our discussions today, remember that the ultimate goal is that reduce morbidity and mortality. People will live longer. So this work of the Right Care Initiative is led by Hattie Henley, and her energy and her input and her zeal is what keeps this going, even in the face of a pandemic. But she is not doing it alone. So what I would like to do is recognize the leadership of the Right Care Initiative. So I will go through, and I would just like those that are on the line that are leadership just to acknowledge when I note you. Dr. Bill Bonner, William Bonner.
Yes, sir. And thank you, Oliver. You're doing a great job.
Thank you. Thank you, Dr. Bomber. Stephen Chin, Dr. Stephen Chin, Pharm D.
Yeah, and I'll concur. Great framing, Oliver. Thank you.
Thank you. Dr. Scott Flynn, is Scott on the call today?
He is not able to join us today.
Yeah.
He's one of our greatest regulars and longtime leader, but he has a triple conflict today. He'll be back with us on the last Tuesday of the month from 4 to 6.
Yeah, we will give him a one-time pass today. All right. Cindy Giambroni.
Hello, everyone. Thank you very much. Thanks for facilitating this meeting, Dr. Brooks.
My pleasure. Susan Ivy, I believe Dr. Ivy, she's going to come on later. Is she on now?
Nope, I'm on now.
Yeah, okay, good. Thank you.
Thanks so much, Dr. Brooks, for moving this meeting along, and I'm excited to hear this topic.
All right, excellent. Me also. Dr. Sky, Dr. Joseph Sky. Okay.
Hello. I'm glad to be here and excited to hear about especially the community health workers today.
Thank you. Okay, Dr. Carol Zaire.
Hello, I'm here.
All right.
Hey, Carol, so nice that you're with us. I see we skipped over Dr. Wanacott. Wanacott, would you please unmute yourself? Thank you.
Yeah, I think I wasn't originally thinking I might make this. The pandemic has changed my schedule tremendously, and but I've been with Right Care Initiative for the last 8 years, and grateful to join you today. Thank you.
All right, thank you. And yeah, we want to leave out no one. So the focus of today's discussion is focused on, as Hattie said, increasing the patient care team. And today we're really looking at community health workers. I think that it is really important to have that because we can't do it alone, just like we can't do Right Care Initiative alone. And there is clearly a role. I mean, what are we treating? We're treating the community, a community health worker. So I think that kind of one of the themes I think of this is that it really ultimately is simple. There's a friend of mine who wrote a book called Simple, Not Easy. So simple is not the same as easy. So I think it is imperative that we look at expanding the care team, and the community health workers are a part of this. So I will introduce the first presenter, the first speaker, and happy to have him, Dr. Rishi Manchanda. And he will be giving us policy and evidence, integration of community health workers into health systems. Dr. Manchanda is founder and president of HealthBegins, a social enterprise that provides training, clinic redesign, and technology to transform healthcare and the social determinants of health. We've heard a lot of that. Dr. Manchanda is dual board certified in internal medicine and pediatrics, a member of the National Physicians Alliance, and a fellow in the California Healthcare Foundation's leadership program. He is also active with the PHR, Physician for Human Rights. I like them and know them, and Doctors for America. He's the lead physician for the homeless primary care at the VA in LA, where he's built clinics for high utilizer homeless veterans with complex chronic diseases. He's the first director of social medicine and health equity at a large community health center network in South LA. And I'm interested in the fact that they even had a director of social medicine and health equity. That's excellent. In 2008, he started RX Democracy, a nonpartisan coalition that has registered over 30,000 voters in doctors' offices and hospitals nationwide. 2013, his book, The Upstream Doctor, I guess not the extreme doctors, introduces a new model of healthcare workforce that includes clinical upstreamists who address social determinants of health. He traces his roots in activism to his undergraduate participation in the Peace and Justice Studies program and his days interning at the Lincoln Filene Center, where he explored concepts of civic engagements. I won't even go off. He Tufts, UCLA. So he has that in his background. I'll just close. His dedicated leadership inspires advocates of all backgrounds to speak out for public health. Dr. Rishi Manchanda.
Dr. Brooks, thank you so much. And thanks to everybody at the Right Care Alliance for letting me join you guys today. I'll update the bio briefly to say I'm currently a CEO at HealthBegins, which is an organization I founded in 2012 when I was transitioning from work in South Central Los Angeles, as Dr. Brooks mentioned, when I was at St. John's, just down the road from Watts Health Center. And then was going over to the VA to be the lead primary care physician for homeless veterans there. HealthBegins was founded to be a professional home for clinicians like myself who were, like all of you, I think, acutely aware that these upstream factors in our patients' lives, like food, housing, transportation, social isolation, all these things have profound downstream implications for our patients' lives. And in an era where we're more responsible for value and not just volume, but we're more responsible for outcomes and not just outputs, it was clear to me that at least in 2012, when we first started HealthBegins, that there needed to be some sort of way to swap notes, share best practices, be able to drive improvement to address one of the major drivers of better outcomes and better value in healthcare vis-a-vis broader public health, which is addressing social needs or social determinants. I'm going to focus today for about 16, 17 minutes. I'll try to keep us on pace here because I want to be intentional to pass the baton to Maria Lemus, who is the executive director for Visión y Compromiso. I was honored to get this invitation, but one of the things that I'm also really pleased about is that the organizers of this event were also very immediate in responding to a suggestion I made, which is to invite Maria to actually co-present with me. So I'll spend some time just level setting and then turn the baton to the real resident expert on this call, at least, and that's Maria and many of her colleagues. If you can advance the slides, please.
Dr. Manchanda, pause for just 1 second. I left something out to all those participants, very important. We will have breakout sessions at the end of this. And the reason why I interrupted Dr. Manchanda is that we will need your input, those participants on the call. What we're going to ask you to do is listen closely to the presentations, and then the breakout sessions, give us information, give us something that you gleaned from any or all of the presentations that you feel you can take back to your site of influence, where you work, where you operate, that can improve the operations there. So keep that in mind. There will be a string of pearls, I will say, in the presentations. And I wanted to stop Dr. Manchanda because I know he's going to be giving us some. So there will be 4 presentations. This is number 1 of 4. So for all of you on the call, do keep that in mind. So just take some notes and we'll look forward to your participation. Sorry about that, Dr. Manchanda. Please continue.
No, by all means, thank you so much. If we could advance slide, please, for the next one. So a quick level set, community health workers and Promotores de Salud. Maria is, I won't go too much into this because I know you're going to speak to this more directly, but some basic definitions. From the American Public Health Association, the definition of a community health worker is a frontline public health worker. I'm going to pause there. A frontline public health worker who is a trusted member of and/or has an usually close understanding of the community served. there's some additional detail there. There's varying definitions also of Promotores de Salud, and I'll defer to Maria's definition there to describe. This is just one that I find sometimes helpful, but we'll defer to Maria in terms of defining both community health workers and Promotores de Salud. It's a diverse group, and it doesn't align with just one definition in ways that I'll try to explain in a minute. If we can advance the slide, please. I'll just say next slide going forward. So for now, thank you. We'll stay on the slide. Some quick context setting. According to the Bureau of Labor Statistics, there are at least 5,720 community health workers estimated to be employed in California. This is as of data from May 2019 from BLS. This does not include those who are employed or partially employed or engaged as volunteers. It does not include necessarily Promotores de Salud, of which there are many in California as well as the country, as you're going to hear soon. But it is helpful to get a quick lay of the land. As you can see here on the map on the right, it's important to understand the number of community health workers and overall Promotores de Salud as well in the context of the population density. And you can see that California, while we, in terms of absolute numbers, have a good proportion of community health workers and Promotores de Salud in California, we have many in the state. Relative to other states, for example, Alaska, where you can see here depicted in the deep red, based on our population density, we don't have nearly as many. And let me go to the next slide, please, to put this in a little bit more context. Let's look at the global context. Some of you may be familiar with, of course, California's demographics, right? Almost 40 million people. We are a really rich state based on one measure, at least, in terms of gross domestic product per capita. We're about $59,000 of GDP per person in the state. And we have about 5,700, as I said, community health workers, at least on the, and there may be more, likely to be more. You can see some of our data in terms of COVID-19 cases here on the left, and as of at least a couple of days ago, the number of deaths due to COVID directly. It's a tragedy, it's eye-opening. One of the things that might be helpful is to look at, when we're talking about community health workers, understand that in the US, including in California, the basic framing, the basic way in which we've actually understood health actually has a lot to do with why we see the distribution or the lack of the number of community health workers and promotores involved as closely with healthcare. For example, there's a state in Southwest India called Kerala. It too has a population that's roughly equivalent to California. It's about 35 million people. The GDP is much lower per capita than California, $3,200 per capita. So far less than the per capita GDP in California. And yet community health workers in India, they're called ASHAs. It's an acronym that stands for essentially the community health worker model in India. There are at least 28,000 community health workers in India, in Kerala, particularly this state. Cases there, there's a variety of reasons that this is an association. I'm not necessarily implying causation here, but it's important to understand that the case rates there are lower. Case rates are, of course, increasing across India, but the death rates are much lower in places like this. Context matters. Understanding this question of community health worker in the context of what it can do within a care team is important. But if we understand that question without looking at if we approach that question without understanding the global history and the context of how community health workers have evolved as an occupation, as a profession, if we do that, we'd be limiting ourselves to a very myopic kind of perspective. And that would limit us to, in terms of our ability to fully understand and appreciate the culture and the value and the power that many community health workers bring. And that's from my direct experience. Go to the next slide here. I speak fast, so I'll pause every once in a while just to take a breath, but also to review any questions, and please let me know if I'm going too fast. I want to make space for Maria. One of the projects that HealthBegins is involved with, my organization, is with support from California Healthcare Foundation. Since May, we've been convening calls with community health worker and promotora leaders across the state, as well as allies. You can see some of the stakeholders that have been engaged and that have been involved in these regular calls for this kind of coalition here on the right, from employers to training entities to membership associations to allies involved in advocacy in terms of public health in the state. We've had a diverse stakeholder list of community health worker leaders and allies. This project will go through the end of October and will likely continue in a different iteration afterwards. The main goal has been to convene to identify concrete opportunities to respond to things like contact tracing efforts or to broader issues in terms of healthcare, including work to identify bright spots. In other words, concrete, potentially replicable ways in which community health workers and promotores have been involved in meeting the moment and rising to the occasion in ways that in the news media and in the healthcare media, we haven't really given much attention to. Community health workers have been doing a phenomenal job, as is expected and as is traditional for community health workers and promotores, have been doing a phenomenal job at meeting residents, particularly those that are the quote unquote hard to reach by healthcare systems, meeting them where they're at because of this deep sense of trust. Let's go to the next slide, and I'll give you a brief glimpse of what these bright spots look like. What we've learned from this work, or this one project, let alone various other initiatives that HealthBegins and our allies like Medicaid Group are involved with, what we've learned is that community health workers perform a range of roles and services across sectors. This has been true for the past several decades across the world, including in the US. There are value propositions within and across different sectors. For example, for public health on the left, for social sector organizations, for healthcare, which is of course where all of you are primarily based, and then for social justice. It's important to note that community health workers are by definition defined by community, not by a payer or not by a plan or not by a patient panel, right? By community, it's in the definition of the word, right? And so as such, they are by definition cross-sector workers. They work across sectors, and the true value of and the power of their work often comes because of that cross-sector work. And you can see how many of the services and roles that community health workers, promoters, Salud perform really cut across these sectors. On the next slide, I'm gonna ask you to click through whoever's doing this. So let's click through it, and you're gonna see a lot of different bright spots from a recent survey we just did. About 30 organizations took part in this, and you can see, maybe focus in on whatever bright color jumps out at you. We'll stay here for just a moment. Take a look and you'll see these are responses from about 30 organizations so far. The survey continues, so we're hoping we can hit at least 45 within the next month. But so far, 30 organizations in California involving community health workers, or Promotores de Salud, you can see a variety of different ways in which they're all helping out. Bright spots in ways they've helped, for example, engage severely mentally ill homeless individuals through street medicine outreach, engaging patients as part of COVID, of course, contact tracing and isolation and quarantine support, providing care coordination support as well, seeing a surge in interest in community health workers. So if you didn't know about community health workers or Promotores de Salud before this, or if you knew just a little bit, you should know that there's a rich, diverse, dynamic kind of amount of activity that's happening in the state, and oftentimes we in healthcare have just been blind to it, to be quite honest. These bright spots are a way to illuminate, right, the fact that there's a lot of incredible energy that's happening within this state and across the country. Maria will expound on that in a moment. The next slide, though, allows me to, I'm going to start focusing in on some of the various roles and issues within immigration. I'll skip past this slide. Just know that we'll share this copy with you if you haven't got it already. You can see some of the common activities performed by community health workers, at least based on the survey we've done. And this is consistent with what we're seeing in many parts of the country as well. And some of these are public health value propositions, some of these are healthcare value propositions, and so on. The point is, they're doing it all, and they're doing it incredibly well. The next slide, please. All right, so the meat of this, my talk is really to kind of dive into the evidence base that's existing out there right now. So the next slide, I'm going to start to unpack this in quick order. By focusing in on this primary kind of value proposition right now, again, recognizing that there is value across these sectors, we also recognize that many of you are interested in looking at the healthcare value proposition. So it's important to understand that while we're talking about the evidence I'm going to show you right now, if we only limit our understanding of the true impact of community health workers or promotores within the healthcare lens, we will actually underestimate the overall impact across sectors. I'm looking for head nods. Does that make sense? That's a major kind of element here. Next slide, please. All right, let's dig in. The Association of State and Territorial Health Officers, ASTO, along with the National Association of CHWs, recently compiled a summary of the most effective, the evidence of CHW's effectiveness, particularly in healthcare. And these are some snapshots from that wonderful report. The link to it is below. Of late, what we've seen is a number of studies, including randomized controlled trials coming out. There's been a surge in the past 2 decades of community health worker related research. Some of them, and the RCTs you can see on the left, demonstrate that when part of care care planning when being able to provide action plans and support in terms of care coordination. The results are pretty interesting and undeniable from an RCT perspective. Through an RCT, the first one linked, you can see on the top left here, the results that came through a CHW intervention were an increased likelihood of obtaining primary care, improving mental health, decreasing the likelihood of readmissions from 40% to 15.2%. Again, an RCT. Second study here on the bottom left, again coming from our friends at the Penn Center for CHWs, showed similar impressive results in terms of disease self-management, lower hospitalization rates, and so on. There's other research that shows, that looks at not just in this RCT kind of model, but looking at some other methodologies to start to understand the value of community health workers when it comes to chronic disease management. So for example, you can see here on the right with the Maryland study, when they looked at a model that included nurse care managers as well as community health workers related to diabetes, which I know is a main focus for the Right Care Alliance, you can see here, particularly among African Americans, benefits in terms of A1C reductions, cholesterol, and blood pressure. I guess the trifecta for what you guys are looking at with the Right Care Alliance. The question stands, like from this research and the research that ASLO has so nicely compiled of, over the last 20 years, the question is, when we're providing the best standard of care, and the evidence base suggests that one of the best standards of care is to involve community health workers, the question is, are you adhering to the best standard of care if you're not introducing community health workers into the mix? I think the aspiration here, especially the spirit, I think, of this call and the interest that you all have, is recognizing that this is an opportunity to finally actually integrate community health workers and follow the model that many health systems around the world have done. Let's go to the next slide. Some of the things about the evidence, of course, points to this question of return on investment. I want to really kind of drill in on this point here, not to review all the return on investment interventions or studies that have been done, and some of them are examples on the right, many of which show that the ROI ranges from about $2.50 to $15 for every dollar spent. That's impressive, right? It's impressive for any intervention to have that type of return on investment. And there's now accumulated evidence right now that shows that in the various different models that have been evaluated so far, the preponderance of research now suggests that when done well, community health workers can lead to an impressive ROI. I want to stipulate that I want to ask all of us to stipulate that that's actually, the evidence is there. And there are citations here in this slide we're happy to share with you all to allow you to kind of dig into this more. But I want you to accept that the ROI evidence is strong. Community health workers in healthcare systems produce better return on investment. But before so I want you to acknowledge that, and the research, as you'll see, supports that as the slide summarizes. The main punchline I want to make, however, is this. Why is ROI mentioned in certain conversations, particularly around community health workers or even upstream social determinants of health, but omitted from others? As David Ash and others in the New England Journal of Medicine actually spoke about in 2016 in this really wonderful article that didn't get a lot of press, which was called Asymmetric Thinking About Return on Investment. The question that David Ash and his colleagues posed is, why do we focus so heavily on ROI when the topic is chronic illness, but rarely mention it when the topic is cancer? The provocation that in this article that the authors provide is this. ROI, asking the questions of ROI, is, for me, in our work across the country with health systems and physician groups across the country, we work with the American Medical Association, APG. HealthBegins is neck deep with our allies in healthcare, helping them to move upstream. And in all those conversations, we see this one common through line, and this may be common for your experience. When ROI is being asked in the context of moving upstream, rarely do we pause and ask if we're applying that same analysis, that same feeling of rigor to many of the other things we're doing in healthcare. For example, one thing I'll provoke in asking this group is, do you know what the return on investment for your health system is for your community? Can you quantify it in dollars? And should we ask you to pause on your work and determine whether we should, as a society, invest more in your health system until you prove your ROI or demonstrate it through solid evidence? You see the framing, right? If you can't enumerate right now the return on investment for your health system or your medical practice in terms of the economic value to the community of all of the health benefits that you might generate, the question is, if we can't do that ourselves, are we holding an asymmetric kind of conversation of expectations, at least when it comes to CHWs? So point one, CHWs produce remarkable ROI based on the evidence to date. Point two, let's always ask ourselves when talking with our colleagues internally as well as with stakeholders, if you're having a conversation about, well, I need to wait for the ROI, I need to review the ROI for a community health worker to justify their expense in this team, ask yourself if you're doing that in other conversations with the same equanimity. And my challenge would be, based on our experience, people are not. And that's actually a very illogical kind of approach, right? It's important to actually pause and ask ourselves that question of the framing of ROI questions, let alone the substance of them. Let's move on to the next slide here. Just mention a couple of other things. Our friends at George Washington University about 5 years ago, and others have done similar studies, have looked at what makes CHW integration more effective. So we know that ROI can be achieved. We know that healthcare benefits and health utilization benefits can be achieved. The question now is, how do you do it well? When it comes to doing it well, when it comes to integrating community health workers and promotores well into healthcare systems, it's important, I think, to understand that there are a variety of models. And they range from, as you can see in the column on this table here on the left, from direct hire models where the health system or plan is engaging or hiring directly, to all the way to independent relationships where you're contracting with independent entities in the community. And I'll defer to Maria and the conversation in the breakouts to have you start to determine what model might make sense based on your own experience, what many of you have done. Traditionally, as GW and others have found, healthcare systems like to have direct hires in many cases because that control is there. The challenge is, of course, that may not always equate to the most effective means of integration. Because, as I see in the second bullet on the left, the quality of integration, irrespective of the model that you choose, whether it's direct hire or engagement, the quality of that really depends on three major domains. How have you actually made sure that communication about patient care is clear and community health workers and promotores have the ability, for example, to easily inform providers and vice versa about patients' needs? How is provider expertise shared? Are CHWs expertise valued, recognized, enumerated? And are there opportunities for them to join conversations to strategize about a patient care model? Rather than being extenders of a healthcare team, are they seen as people who bring unique value and expertise in and actually not only inform providers, but train them as well? I would love to see a day in which actually all of your health systems, if you're in an academic setting, provided grand rounds led by a Promotor de Salud from Maria's group. That would be the challenge a year from now, to have Maria's group or some other organization in California that does a CHW present a grand rounds at your institution and not just be in the audience to listen. The last one is autonomy. And the evidence, again, clearly demonstrates that effective CHW integration relies on providing a high degree of autonomy and clear supervision for CHWs and promotores as well. The last slide I'll present is this. Here's what the evidence clearly suggests from a policy perspective as you think about institution. When you pursue, as you all probably are doing already, integration of community health workers in healthcare, avoid undermining their intrinsic value and their power. Do it the right way. Despite a rich history of providing essential services in the US, community health workers have long been marginalized relative to physicians, nurses, and others in the formal healthcare workforce, and the same thing could be said for the formal governmental workforce. As healthcare is shifting towards this right now, we're recognizing the so-called emerging occupation. It's like the occupation's been there for a long time, and now it's being recognized as emerging by healthcare. We need to reframe this and recognize that we actually are opening our eyes to a long-standing occupation. The last thing is the way in which you choose to integrate, the quality of the integration that you pursue, the amount of resources you dedicate to this will actually determine not only the shape of this occupation, but the shape of healthcare itself. And you can see here this excerpt on the right, my parting comments. The second paragraph that came from a really wonderful article that described the different models for community health worker engagement in healthcare. There's one model in which community health workforce serves the community by engaging in empowerment and advocacy work, and another where they're part of a professionalized, specialized workforce. The latter may be more readily acceptable to all of us in the healthcare system, but it also might represent a break. It would represent a break from the historical roots of the community health worker movement, create barriers to entry into the profession, and diminish community trust in community health workers that is arguably the core impact. In integrating community health workers into healthcare systems, the evidence suggests that there is immense value, potentially, but there's also immense potential risk, which is to actually undermine the very trust that community health workers have built over many years and decades in their communities. And in terms of how to integrate in the teams, if you want to put a premium on that trust, which is the main kind of value proposition for a community health worker at Promotores Salud, you have to trust them. And trust is not just in words, it's in actions. In the contracting, the payment, the supervision, the autonomy that's provided. The evidence suggests that resoundingly. I think many of you have this experience working with community health workers could probably attest to the same. With that, I'll turn it over to Maria. Maria Lemus, the Executive Director of Visión y Compromiso. I'll skip past these slides because I think I've gone too long. So let's just go to Maria. And Maria is a legend in the nation right now for Promotores de Salud, and is a mentor for myself and someone I count as a friend as well. Her bio is extensive. I will just note that as you read this yourselves, understand the role that she plays both in California with the National Association of Community Health Workers in the nation, across the country. She's long been part of being able to give voice to Promotores de Salud and being able to engage healthcare systems, and has a world of wisdom to share. So Maria, without further ado.
Thank you, Rishi. That was a great presentation. I hope I can build on what you shared with everyone. So welcome everyone, and thank you for the invitation, Bob, and everyone else. I'm really happy to share about our work, Visión y Compromiso, and really the promotor model for community transformation and well-being, which is a lot of what we've come to. We're celebrating this year our 20th year as an organization. When we came together 19, 20 years ago, promotoras who met each other and who found commonalities. We discovered that I knew Juana, and Juana was doing the same volunteer work. 20 years ago, most promotoras were volunteers, and community health workers were very limited at least in institutions. And so we came together and we said, well, we really, I know this other person, I know this other person. And before you knew it, we had probably 100 promotoras that were interested in continuing the discussion. We started in 5 regions. We now have 13 regions. We're in other states. We provide leadership, training, and advocacy for nearly 7,000 promotoras across California, other states, Mexico, and Guatemala. And I'll share what the common core is of the work that we do. Who's advancing my slide? Could we? Thank you. I did want to talk a little bit about the history of promotoras and the work that we do in the community. Here you'll see a slide that really talks about the history of who these wonderful men and women, and the majority are women. On the left, you'll see the Felders in Russia. You'll see barefoot doctors in China. You'll see in Latin America, in Africa. This concept is not new. It has been around, I say, as long as Eve was a grandmother. It has been around forever. And because it's centered on community and community sharing and working with each other, there's a rich history outside of the United States. If you could move the slide, please. And of course, we know that the World Health Organization supports it, community participation in health, and the Ottawa Charter also support that in peace, shelter, education. These are really, these are statements that have been around for many years, and we base a lot of the work that we did initially in the development of the network and the development of Visión y Compromiso on these international concepts. Another slide, please. So who are promotoras? This is a view of some of the promotoras. We're different sizes, we're different heights, we're different colors, we're different ages, we're mothers, we're single, we're men, we're fathers, we're single men. A promotor has many things in common, and I wanted to share what some of those are. If we could go to the next slide. Promotoras are known through what we call a continuum of promotor to community health worker. They have diverse roles and functions. Initially, 20 years ago, there really was a very clear separation. You were a promotor, you were a volunteer in the community, or you were a CHW, a community health outreach worker, for instance, in the AIDS epidemic, which is where I first met community health outreach workers when I worked for the San Francisco AIDS office. And then, and I know that there are many in between. And the titles typically are defined by the funding. You have categorical funding that oftentimes will define what the title is, what the project description is. But what is core to the work that we do, if we'll go to the next slide, what is core to the work that we do is really what we call the espíritu de servicio. And the spirit of service is what initially guides the promotor movement. It is, if you can think of someone in your family who is taking food to others, who is helping with rides, who is caring for people, that's the promotor. That's what we call the spirit of service, the espíritu de servicio. It was my mother in our community. I grew up in San Bernardino, California. My parents were immigrants from Mexico. My grandmother was the local healer, and my mother was the promotora. So I grew up in an environment where I knew that we were always giving, taking care of each other. I had an uncle who could do this, an aunt who could do that. My grandmother was the healing. It worked really well in a time when you grew up in segregated America, where you really could not go outside your environment. And I grew up with that. I say that for the sake of being American, that is being acculturized in an era when you were a melting pot. You had to lose all of your characteristics of whatever country you were from, and you had to become this American melting pot. You lost a lot. And I think that in losing that transition from being Mexican to being American, you lost those traditions that were core to you. And I was blessed to find them 21 years ago, 22 years ago, again, to refine and to see promotores and to recognize that this is a way that I grew up with, and then find that there were thousands of us who also grew up the same way. This picture is a picture of a woman named Maria Luisa, who passed away about 3 months ago. She was, her father, she's half Samoan and half Mexican. And I put her up because she, to me, was a great example of the service from the heart. She volunteered. She was a nurse from Mexico, but she volunteered. She did everything for her community. And we believe that if you continue to support that individual through training, through leadership, and really build up the capacity of the individual that their families will change. They will change first, as you saw Maria Luisa. And then they will influence their families, and the families will influence their community. Now, this is something we discovered, we came up with 20 years ago. The leadership across California when we came together. And we still hold true to that, because that's what we're seeing in the community, is we're seeing the promotoras are influencing change. We're seeing second and third generational change now. And it's especially important, not just through advocacy and through leadership, but to see that it is possible at a time when things are so desperate that things can get a little better. The next slide, please. We say that we're effective catalysts for community change and support. And here you'll see some of the examples, the servicio, where we're really sharing and helping other people. Typically, we have shared information, and we've been known for our outreach and education. Early on, when we started going to APHA in 2003, and we were part of the Community Health Workers SPIG, what we were saying was that our work is greater than the public health arena. And we knew that, and we said that because our network, which is now 7,000 strong, really embraces promotoras that are in every sector. So what Rishi mentioned across sector is we found over 20 years to be very true. Promotoras are in Girl Scouts, they're in resource centers, they're in domestic violence, they're in health, they're in mental health, they're in churches. Wherever you find that espíritu servicio, that is where a promotora lives and serves their community. And so we're really trying to support that person, to build out their capacity to be able to engage their community in health and wellness. So over time, we have moved from an outreach and education group to really being part of the mitigating health. Can we go to the next slide? So we call this the community transformation model, where we, through our work in continuing to train and to build the capacity of the individual as well as the community, we find that we build egalitarian relationships. That sharing of information allows us then to really build community participation. And where we are now is it has led us to increase individual and family health. So you'll say, well, what does that mean? That means that community has built out programs to support each other I think what's really important is the reason I'm stressing community is because at a time when the resources are few in community, the funds are few in community, there's little expertise in community, we have been able to build out a system where we have, for instance, Me Veo Bien, Me Siento Bien, which is a nutrition program. We have a bailoterapia, which is an exercise program where we train and certify instructors. They go out into the community and offer exercise and wellness programs for the community for free. We cover their insurance, and so they're able to go out and the community can participate. It's in their neighborhood. And we also talk about nutrition and exercise. This was developed, these programs were developed about, I'd say about 10 years ago when we had a grant from the National Blood and Heart Institute to really look at reducing high blood pressure and cardiovascular. And so we developed these programs in the community so that they were cost effective, they were accessible, and they were really integrating the promotor model so that if I had hypertension, somebody would come to me and say, Maria, how are you doing? I would say, well, you know, I have hypertension. I don't really know what to do. I'm supposed to eat this and eat that and exercise, but I can't afford to go to a gym. I don't know how to cook this other food. Well, our programs, promotoras, can go out in the community and somebody will come to me and say, well, let's see how we can cook this better. And then let's go for a walk. I'll go with you. Or there's a bailoterapia class over here. These are really important things that the community is able to design for our community. These are just two examples of what goes on across California every day. Other community-based organizations are really developing systems to serve their community. And they're not usually recognized within the public health system because they're not part of a study or they're not part of the usual suspects that provide service. But I really want to honor community because we're able to create systems for our community without cost and that are relevant and that are culturally and linguistically appropriate. I live in El Cerrito, which is near Berkeley, and near me in Richmond is an example of a center that with so little money, it's amazing what they do. It's run by a Latin, well, they're all Latinos, but it's run by a Latina from Peru, an immigrant herself. And whatever obstacle comes up, they think about it, they develop resources, they do potlucks, which is what we used to do. We used to do potlucks and really look at how we can come together to provide a resource and support for our community. Much as I mentioned, we did when I was young. Our community would chip in, my uncle would do this, my tío would do that, the neighbor would do whatever, and we would all come together to support each other in the development of something. I think that those resources are still there. I know they're still there. I think we as institutions need to really honor what is historically clear for us as a community and honor it and integrate it into a public health system today. If we can go to the next one. I just want to mention here that the promotor model is really centered on popular education. We were blessed as one of when we first started learning our craft as promotoras. I mean, we were promotores, and I am a promotora, but we also learned from other expert promotores. We went to Cuba in 2004 to learn about integrated healthcare. We went to Mexico to learn to Guanajuato to learn about how grassroots building is, and then we had one of the renowned experts teach us about popular education, Rosa Marta Zarate, who learned her craft from Freire himself when he was in Mexico. So as an organization, we learned our craft in addition to naturally being promotoras, but it is centered on the promotor model and on popular education and how that's integrated into our life. You can change the next slide, please.
5 minutes remaining.
Thank you. The health equity and social determinants of health, I kind of want to focus on this because promotores can influence social determinants of health, and you check off the boxes. Because we're across sectors, we influence all these things that affect us. Our income, I just want to stress our income is really important because we think that a job is critical to a family's well-being. And that's where we have moved into into workforce development and workforce initiative. Over the years, our base building, our trainings, our capacity building has led to promotoras being hired not only in the public health system and the mental health system, but in other jobs. And so we have a workforce initiative where we're continuing to train promotoras at the grassroots level so that they can be employed by agencies while working with agencies to introduce them to the promotor model so that there's a happy in between, so that they're able to embrace the promoter model in their organization and have it succeed and flourish. Please go to our website where you will see some of the papers that we've written. This is a great example of some of the programs that we have where we constantly are training and teaching and sharing information, building the capacity of promotoras, whether they're volunteers, whether they're staff. Go forward. And we work with clinics. If you would go to the next slide. We work with clinics, with hospitals, with counties. Here it'll show you that promotoras reduce disparities. They're the ones that connect to the community, their local workforce, they're cost effective. I did want to just say one thing about what Rishi said about return on investment. We call it return on investment for community, ROIC. What is the responsibility and the benefit to the community? We've been saying this since we started to look at workforce. The agencies and the organization's responsibility should be to the community in a way that's responsive to the community needs, either through workforce or through providing better services, certainly through hiring and developing programs for them. We know that promotoras have this intersection between families, communities, and the healthcare system. And we know that they're successful in the healthcare system if the system will allow them to come in and play a real role. Next slide, please. This is just, I did want to say, we are not hard to reach. You just don't know how to reach us. That's something that promotoras say all the time. And I'm going to leave these slides with you to look at. But these are some of the things that we can do and we have done successfully. Next slide, please. Next slide. Next slide. And then our challenges and opportunity is in this slide. It is that we are so, there is a difference between a promotor and a community health worker in theory in the way that they work. And to focus only on the community health worker side where it's institutional, organizational based, and to forget the importance of bringing the promotora along the path so that they're the ones that you can hire, they're the ones that can work and implement these programs is really a disservice to the organization and to the service agency. We must work hand in hand so that we build the capacity of community, these leaders, whether they have an education, the education level that you're seeking or they don't speak fluent English. That really is not the point when we're talking about promotores. My mother was a promotora. She never spoke English. She didn't have a high school degree from the United States. But she was who you want to look at. And unless we start to bridge these two arrows and look at building community out, the unintended consequences is that you will keep hiring Spanish-speaking non-Latinos, which one, defeats the purpose, and two, doesn't really build the community capacity. Next slide, please. I did want to stress one thing about building community capacity, that it is important to partner, and we think that going to scale means partnering with community. So there has to be focus on building up the capacity of community-based organizations who are really the ones who are training promotoras right now, to build them up so that they can engage with clinics, with hospitals, with health systems, with plans, so that they're the ones who, one, not only can benefit, but can really give that, build up the resources for local entities. One more slide, I think. And how do we get there? Please just look at some of these slides. Support the integration of promotoras, continue to support community training, integrate the model, support the capacity of CBOs. We have an alliance of over 100 grassroots CBOs that we work with, helping them with organizational capacity as well as with training and building up coalitions. That's really, I think that that's a really important step that we have to look. It's not just taking a person and putting them into a situation where you're providing training. It is building up that personal capacity, the community capacity, and the organizational capacity to be real partners in this fight. One more, please. And I think we're done. And then our vision is Hacia una vida digna y sana, which is working towards a dignified and a healthy life. We developed that 20 years ago, really believing that it's just not the physical health, it is the community health, and it is the dignity of living in the United States. As my parents came here and wanted for me a richer experience and a healthy future for me and my children, I've been able to do that, and that's what I think we all want. This model works and has worked in other communities. We're training in African American communities and also in Asian Pacific Islander, because we all have the heart. We all have promotores in our communities, and we all want a better life for us all. So thank you very much. Please look at the slides a little deeper, a little closer, and visit our website. We have our annual conference, 20th celebration, coming up in October. It's a virtual conference. Typically we host 1,000 people, but we're doing it virtual. Please join us. Invite anyone to come and listen to what we have to say. We have workshops, and it's a great adventure. And I think you'll enjoy being part of Visión y Compromiso. Thank you very much.
Well, that was fantastic. I don't even know where to begin. I've been fortunate in my career to have worked with CHWs. You're preaching to the choir, and Maria, Dr. Manchanda, great overview. I didn't want to, as you're going through the presentation, Dr. Manchanda, I was thinking you could substitute community health worker with pharmacist, especially community pharmacist, and have the same presentation. Right, so there's data from U.S. Public Health Service, ROI from pharmacists, 3 to 12 to 1. We're not physician extenders. We bring a new expertise in medication safety and efficacy, and there's limited opportunities for us also to practice to maximum scope allowed by law. It's really funny. I just think we need to look at some more opportunities, Maria, to partner CHWs with pharmacies. Hope you agree.
I'm ready. I'm ready.
Right. Excited. I mean, there's like 90% of the U.S. population lives within 5 miles of a pharmacy, and so there's definitely some opportunities there. So thank you for that. I have the pleasure. I'm sorry. Go ahead, Dr. Manchanda.
Yeah, just a 2-second plug for that, just to piggyback on that point you just made. In the latter part of my slides, and maybe folks can look at it a little later on, one thing I teed up was how health systems can not just engage CHWs, but also get involved to help support this broader kind of effort to center in the community. There's a community-based workforce alliance that HealthBegins and other allies have formed. Maria and Visión y Compromiso are members of this alliance. Organizations like Families USA, the IHI, Partners in Health, a lot of organizations across the country are now part of this. We invite health systems, if you're thinking about integrating community health workers, or for that matter, community-based pharmacists, to think about how to join this community-based workforce alliance, because the point is that there is immense value in the community-based workforce, whether it be a community health worker, a promotor de salud, a community pharmacist, as you said, Steve, or others. So more information about how you can get involved in the deck. Thanks.
Fantastic. Thank you. I'll leave a quick quote for you. I'd say pharmacists are easy to reach, but you just don't know all that we can do for you. So with that, I'm going to introduce Dr. Jessica Abraham as the next speaker. Dr. Abraham is the Director of Population Health at the University of Southern California School of Pharmacy. She directs our virtual clinical pharmacy program, which is both video and phone medication management. It includes the phone medication management service, which addresses Part D, MTM, Medicare Part D patients for MTM services, medication therapy management. She's project manager for just about everything we do. We would not survive without her, including our California Right Meds Collaborative, which joins community pharmacies with health plans to offer these advanced medication management services in communities where patients live. She's a doctor of pharmacy and residency graduate from the OC School of Pharmacy. She led one of our teams in our Center for Medicare and Medicaid Innovation, Healthcare Innovation Award with AltaMed Health Services, who will be speaking right after her, and she'll be introducing. She also worked in managed care and specialty pharmacy for local health plans. So she brings that clinician payer perspective and experience, which is so helpful to our team and the work she does. So with that, I'm going to turn it over to Dr. Jessica Abraham.
Thank you, everyone. Thanks, Steve, for the introduction. So I'll speak pretty quickly. I'm going to try to catch us up on time. And I'm actually going to speak about one of the examples that Dr. Steve Chen brought up in my little bio over here. So next slide, please. And so basically, I'm going to talk about the clinical pharmacy services that we provided in our CMMI program very briefly. And then I'm just going to give examples of how we worked as clinical pharmacists, basically community pharmacists with community healthcare workers. And much of it has actually already been brought up by Maria and Dr. Manchanda. So it's actually just giving you specific points and specific examples of the way we were able to align so well with our community health workers at AltaMed to provide services in chronic disease state management. Next slide. You can just click through this one so you can get everything up. Okay. So pretty much in 2012, we were awarded a $12 million grant by the Centers for Medicare and Medicaid Services. This grant was to bring community pharmacies into safety net clinics in Southern California as a way to improve med adherence and safety and appropriate use of prescription drugs. And the intended results were to optimize patient health outcomes, reduce avoidable hospitalizations, emergency visits, really, many of the same results that our community health workers, whether they be Promotores or any others, those same goals were aligned to our program as clinical pharmacy services program. We had 10 teams across AltaMed clinics, and the teams consisted of a pharmacist, a resident, and a clinical pharmacy technician. That was the pharmacy team, but really our team also included a community health worker, because at our AltaMed clinics, most of us had what they called a promotora, which was our community health worker. Our program also stemmed to do some telehealth clinical pharmacy. So for sites that needed the services, but maybe didn't have a population that was large enough to have a dedicated pharmacist on site, or maybe they were farther out geographically, et cetera, we had basically a pharmacist located at the USC School of Pharmacy who could provide these services by video telehealth to those sites that didn't have a dedicated pharmacy team there. And this program led to pharmacist and resident technician trainings for expansion, as well as a web-based pharmacist training and credentialing. And then the outcomes, of course, that we looked at were the healthcare quality, safety, total cost and ROI, patient and provider satisfaction, which were both above 9 out of 10, and patient access to this increase patient access to care. So next slide. And you can, click through this one as well. So basically this picture is going to show you a really comprehensive diagram of how we selected our patients and what we did with them. So we were after the high risk patients, high cost patients, frequent and recent acute care utilizers. We did this by having algorithms that worked into the EHR of AltaMed. So we looked at 48 EHR embedded triggers so that we could really get those patients who needed the most help. And of course, as the program grew, we also had MD referrals. And besides MD referrals, we actually had a ton of community health worker referrals. Our Promotores, and we'll talk about this later, were one of the best ways that we got many of the patients referred to us. Then when we got those patients, basically we provided the clinical pharmacy services, which I'll summarize in a minute. And they received this comprehensive med management. If the treatment goals were reached, then they were kind of discharged from the program. But they still received clinical pharmacy tech check-ins every 2 months just to make sure that they were stable and remained at goal and weren't having any issues with their medications or their chronic disease states. And then if we found that they were unstable, they were re-enrolled into our program. Next slide, please. So patient selection, this is important because it really aligns to why the Promotores were so helpful. We enrolled 6,000 patients since October 2012. They were predominantly Hispanic, non-elderly women, and 3/4 of them had hypertension with 36% uncontrolled, 2/3 had diabetes with 60% uncontrolled, and then a high rate of hospitalizations. Sorry, next slide. Okay, so the types of services, just to go broad, very quick definition of CMM in case some of you might think of CMM as like a one-time touch. A lot of times people think of pharmacists providing a one-time med review or post-discharge med rec, but this is really everything. We were seeing these patients for months until we felt like the full picture was taken care of. We did a comprehensive med review. We looked at all their meds, all their conditions to make sure that medications were adherent, they were appropriate, effective, and safe based on the wide variety of conditions that the patient had. We helped monitor their home vitals, so we had them take their blood sugars, blood pressures at home. We had labs done for them that we would monitor. We ordered labs, adjusted medications, and we conducted post-discharge medication reconciliation for patients. Next slide. So really why Promotores, and you heard a lot of background about this already, but Promotores at AltaMed, at least when we were working there, their training and their background was, aligned exactly to the areas that we were focusing on. They had training on self-management and evidence-based information on chronic conditions. When at AltaMed, they assisted in diabetes clinic days, other types of disease management intervention programs under the chronic disease management department. They had strong relationships with the businesses and organizations in our service area. Very strong patient advocates, and they had great experience in making referrals to community agencies, whether it be health fairs, seminars, local, cooking class, whatever it was in the community. They knew about it and could connect our patients to those extra services that only reinforce the messages we were trying to provide in our visits. Second, of course, that they were frequently culturally aligned with the patient population. So in our case, if you remember the slide about our patients, they were predominantly Hispanic, non-elderly women. And the promotor I worked with aligned perfectly with that. She was, a middle-aged Hispanic woman who really connected very well to the patients and knew how to tie in all the recommendations we were making as a clinical pharmacy team, but align it to the culture of the patient population. And we have to remember culture isn't just language. It wasn't just simply, just like Maria said, getting a person who speaks Spanish. It was getting a person who spoke Spanish, but truly understood the traditions, the rituals, the beliefs about certain medications, what you thought about insulin versus what you didn't think typical, Hispanic, non-elderly woman would think. Their diet, really looking at everything and understanding everything to bridge that gap. Next slide. So these are specific examples of things our promotores were doing at AltaMed that really helped, again, reinforce our messages. It was never really a duplication, but it was a really nice collaboration. One of the things they did was they assessed the participants' health through simple risk assessments of diabetes, cardiovascular disease, and other chronic diseases. This was a great way where they identified patients they actually wanted to refer to us. So they referred patients all the time to us. They would call us and be like, I'm sitting with a diabetic, she's horribly uncontrolled, has no idea how to use any of her medications, her blood sugars are 300s, can you help her? And they would literally walk the patient over to us, and then we would see them in established care. We also had a method, of course, of making sure that the patients getting referred to us, did indeed meet the criteria for enrollment with a clinical pharmacy team, just to still make sure that it was a cost-effective approach to seeing these patients. Our promotores also were involved in our interdisciplinary team meeting. So it was a meeting with our clinical pharmacy team, the primary care providers, and the promotores, and we were all kind of working together on how we were tackling the issues from different directions to make sure that we were improving our patients' care. As mentioned before, they're very involved with the community. They provided diabetes classes and education around diabetes, asthma, other cardiovascular disease. And these classes and initiatives that they were always running really were towards moving the patients to change, having them engaged, empowered to become better managers of their chronic condition. And that was really the mindset that we needed our patients to have in order to help these patients who had, major clinical in treating their chronic diseases, have had uncontrolled diabetes for so many years and just feel like there's nothing they can do about it. This was really the engagement and motivation that we needed from the promotores, aligned with our medication changes and management to get those patients to actually change and take control of their chronic disease states. So last slide, next slide. So these were just a few other things they did, which really helped, again, align with our services. Following up on high-risk patients, we also did follow up, but a lot of times the time the promotora was talking to the patient, or because the patient trusted the promotora so much, they would call them, for example, when they just got out of the hospital, just de-stressing and talking on the phone. And that was a nice way for the promotora to say, hey, your patient just came out of the hospital, and we would tap in and help figure out, okay, what happened at the hospital, what medication changes were made. We clean up their med with the physician, so when they come see the physician, everything is, clear for the physician. So it was a really nice partnership. It was us with the promotoras and their primary care providers. And in addition, educational materials, we provided a lot of education, but it was helpful to have the promotoras re-emphasize that and reinforce that in lay language, and make sure that there was that understanding of what they could do. It's easy for us to kind of just say, you should eat less carbs and eat more protein, and give that typical diabetes diet that you would recommend. But the promotora stepped in to, give them ideas and recipes about how they should cook certain ethnic dishes they were used to cooking in a better way to follow, the instructions that would help a diabetes-focused diet. And then besides the education, of course, we already talked about the outreach activities that they were able to connect our patients to. So any area where I could think of where we lacked a little bit because we spent more time as much as possible on the medications piece, and then they re-emphasized and stressed those other areas. So as mentioned before, I think it was a great collaboration, and we're so glad to work with the promotoras and other community health workers. That is it. Thank you. Next. So now I actually have the pleasure of introducing two speakers from AltaMed. I'm going to jump right into that. I'll start with Dr. Shapiro. Dr. Shapiro and Dr. Solaris will both be doing a case example talking about integrating community health workers into a multi-site community clinic-based health system with broad plan coverage. I'll start with Dr. Shapiro. He serves as AltaMed's Medical Director of Health Education and Wellness, where he helps create and implement programs and services that expand access to care and improve outcomes for the community. He is a strong advocate for healthcare equality with a deep affinity for innovation and public health policy. His background included many recognitions and award-winning public health, often on the international stage. Something that caught my attention was that after he graduated as an honorary valedictorian with his medical degree, he actually worked as the Mexican Secretary of Health as the liaison between Mexico and the World Health Organization. And prior to joining AltaMed, he held numerous health and leadership roles that focused on traditionally underserved communities and have really sparked his passion for meaningful and community-focused work. He'll be speaking with Solaris, who's the Director for Health Education and Wellness Program at AltaMed. She earned her master's degree in public health from Yale University with a study emphasis on global health. And she continued her education and became a Master Certified Health Education Specialist offered by the National Commission for Health Education Credentialing. And in her current role at AltaMed Health Services, she has been co-leading the organization's Health Education and Wellness Department, where she actually leads a team of 70+ staff members to focus on this chronic disease prevention and management and patient support and addressing the social determinants of health. So very honored to hear the two of you speak about workers and integrating them into this multi-site community clinic setting. Thank you.
Jessica, it's a pleasure to be here, and especially that everything that you 2 or 3 years ago when you started the whole USC pharmacy in AltaMed, it was kind of science fiction. There was really not a lot of data. There was a lot of good faith and ideas, but it's amazing how the role of holistic teams are so important right now for our community, and that's actually why we are here. Next, please. You will see right now that AltaMed, it's non-for-profit. We are a qualified health center. We cater 300,000 patients between LA County and Orange County, and we have been out there in the community for 50 years, and the idea is to continue serving. Dr. Manchanda actually mentioned the importance of Promotoras, and the acute part of being part of the community fabric, and giving back a little bit more of what we're doing. And of course, that being we call it community health specialist, it's more than that. It's someone that actually can make a difference. And don't tell any doctor, but on reality, us as doctor, we're there for 15 minutes. A promotora, a healthcare educator, community health specialists, they are there for life. They are there inside of everything. And sometimes when they pull our ears as doctors and go like, doc, you know what? She's not taking her medicine because she doesn't have money for this, or you know what? There's other stressors. And after that, you understand, oh, I can dance, I can pray, I can send all the medications that I want, but that doesn't change absolutely anything if you're not understanding the social determinants of health, what's happening on the background. Next, please. We have a lot of things, and part of the things that we have, and I'm going to read this quote from us, is sometimes we are too focused on their health, but we overlook the way that they're experiencing at home. And as you can see, we're talking first of social determinants of health, and me as a doctor, I can reach 15%, maybe 20 if I'm very overreaching of everything that I represent in front of a patient. But I'm not reaching that 80%. I'm not even close to that. That means that absolutely everything that happens outside my realm is the things that actually make a difference for our patients. Then we have had this relationship with doctors, and don't tell any other doctor that I said this, but if we integrate actually this type of services as a routine part of care, and it's understood the way that we're actually approaching absolutely everything that we have in front of us, it opens the door. It's not that we are competing against each other. It's just making sure that we're efficient and we're actually helping everybody. And you can see right now that 10% that we have here in the chart is the health system navigation, and you have other stuff, the resource of daily life, and very importantly, the psychosocial support that it's needed to actually get there. Then we have a lot of strengths for them. You need to have actually the right match of the team. We were talking about that you don't need to learn. It's not about the language. It's about the person. It needs to be that feeling that you're talking with your best friend, and at the same time your guide counselor and someone that is kind of your partner in life. And that's what we try to achieve. And of course, we have a lot of challenges that we're seeing right now. Healthcare, it's very in tune with patient healthcare needs, but not the other 90% of things that we're presenting right now. In the past, there was not a lot of tools to evaluate or actually present evidence-based models. And right now, Jessica Solares will start talking about what model we're using. We have been working very strongly with UPenn to in a model that Jessica Solares will be sharing with us. And of course, when you have a promotor in mind, the definition is one, but at the end of the day, there's a huge variability of what is expected and what they actually do every day. Then next, please. Then that's kind of the thing that we have in front of us. Then with all my heart, I want to present Jessica Solares, my partner in crime from every day. Jessica, all yours.
Thank you, Dr. Shapiro. So that's right, we co-lead the Health Education and Wellness Department. And one thing I wanted to say before I start sharing more about the slides is that the value or the perspective that I bring to you this afternoon is from someone who has been within the federally qualified healthcare system for over a decade now. And I've been at AltaMed 12 years. And so this opportunity to be at AltaMed has afforded me the perspective of seeing how the community health worker has been used in different ways. And so that's kind of the perspective that I'm bringing you today, is as someone who's been watching this role evolve within our own system and sharing with you what some of those challenges have been and the measures that we've been taking to strengthen our program. I want to go back to the slide before this one, please, real quick. I wanted to elaborate on something. This pie chart that you see here, I apologize, I did not cite it, but this is coming from one of the randomized clinical trials that was done by Penn Medicine, their Center of Excellence for Community Health Workers. So when they looked at the data at the domains of support that patients wanted to receive to support them with their health, most of it fell into those domains of psychosocial support and health behavior change. And by psychosocial support, what we mean is emotional support, social support, navigation support, which again, I don't think at this point is going to be of any surprise to anyone, right? It's not about more access to care or more medical care. It's really like, help me with these other things, right, that influence my health. And so at AltaMed, we've done really well at hiring the right people that mirror the patients that we're serving. We did have that health education expertise, which Jessica Abraham has spoken to. But when we did a formal evaluation of our community health worker program, these were some of the challenges that we started to really hone in on. We were perhaps too focused on medical needs. We lacked defining patient eligibility criteria. We were very limited in how we were evaluating our program, and we were also lacking a standardized structure. So depending on where the community health worker was based, their responsibilities might look slightly different because we were lacking our own structure. And again, not to say that they weren't doing good for the patient, but we knew we wanted to improve our overall program. And so next slide. So because of those challenges, we decided to really hit the reset button on our community health worker program. And we did so by by adapting and implementing what's considered an evidence-based community health worker model. This model comes from Penn Medicine. They have, again, a Center of Excellence for Community Health Workers. So we've been working for them, and we still are working with them. And so they've had 3 clinical trials with this model, and it's shown to reduce cost, improve access, improve quality. And so, you know, our work for over a year was, how do we take this, adapt it to the AltaMed system, and implement it here? And I'm very proud to share that we implemented this kind of revamp earlier this year, March, just as COVID was about to unleash. So next slide. All right, and so in addition to revamping our model, it also gave us the opportunity to look at job descriptions, look at their job titles, you know, reassess. And what we decided to do was basically to call them community health specialists. This is their formal title, but I want to make it very clear, they are still community health workers, they're still promotoras. We just decided to refresh their title and their job description. So ours are called community health specialist. And one of the takeaways in this process of implementing the new model was that we really needed to revamp our infrastructure and provide them with more support. Prior to the reset, they were reporting to a clinical supervisor. And that sometimes isn't the best person for a CHW to report to, because if that person is, their clinical duties are always going to take priority. And they're not always going to be able to really give the CHW the support that they need. And we had done this for a number of different reasons, but this was kind of one of the lessons that we learned, is that you really want them reporting to someone who is maybe not so clinical. And more importantly than that, that they really do have a true understanding of the role and the value that a community health worker brings to the table. And so we, you know, basically revamped our structure as well. And these are all the key roles that you'll find in our CHW program today. You have the director, someone like myself and Dr. Shapiro. We oversee budgets and the quality of our CHW program. Now we have managers that are only dedicated to their CHWs. Again, before they were split, they were supporting CHWs and other folks and other programs and services within our department. But now we have really streamlined this and carved it out as a very essential and critical arm of our health education department. And so these managers ideally have a social worker background. The model is very structured, and they are, just like the patient provides intense support to the, just as the CHW provides intense support to the patient, that's exactly what the manager's providing to the CHW: intense support, weekly supervision at minimum, reviewing cases with that CHW. We also introduced a new role to the program. This is something we hadn't done before or didn't have before, and that's a coordinator. This person helps with identifying the targeted population, recruiting them into the program, and then of course the CHWs. And I'm very happy to say that all of our CHWs are long-standing CHWs. We've had very little turnover, and they have that expertise of health education and chronic disease management. So these are the key roles that are part of our program today. And what I love about the model that we adapted is that they give us very specific ratios. So for example, one manager should oversee no more than 6 to 8 CHWs, and one full-time coordinator can support up to 12 CHWs. So these ratios have really helped us to streamline the work. Next slide.
10 minutes remaining.
Thank you. So you're probably all wondering, how does your model work? How's it different? So it's a 3-part model, and altogether it takes about it's a 6-month chronic disease management program. In the beginning, patient is setting goals with the support of the CHS and their PCP. The CHS is providing support throughout the 6 months, and then towards the end of the 6-month period, the CHW is making sure that that patient is connecting to more of a long-term support system like a church or a community group. Because the one thing we want to avoid is having the patient feel like a voltage drop, right? I was a part of this great program, I got all this support, and then I graduate and I have no support, right? That's the last thing we want to avoid. So part of the model includes connecting the patient to long-term support systems. We are targeting patients that have diabetes and it's poorly controlled, so an A1C of 10 or greater. Each community health specialist manages a caseload of 25 to 30 patients. So every year they should be reaching at least 50 to 60 patients, because again, the program is 6 months long. And this program is really providing hands-on emotional and social support. And the other important piece to it is we don't want to lose communication with the clinics or the clinical team. It's very important that we stay connected to our clinical teams, especially the primary care provider. And so there's very specific time points where the community health specialist communicates with the provider, hey, this is your patient, I'm working with them on XYZ, and this is their progress. So that happens at the beginning of the program, at the 3 months, and at the end of the program. Next slide. So a really quick snapshot of what it was before, what it is now. Again, the focus originally before the reset, we were very focused on health education and meeting patient medical needs. Now we have more of a focus on what's considered socially focused needs. Before, the touch point was just at the clinics. Patients would come to us, we provide the counseling, the education, the resource navigation, and it was, you know, a referral here, a referral there. Now we're really meeting the patient where they are. This includes home visits, this includes visits in the community. The best example to share with you is before, with our older model, we might encourage the patient to, let's say, walk, right? Start walking, like, let's be active. Whereas in the newer model, in the reset, we would now take the time to actually walk with the patient, set a date and time, a location, meet with them, and walk. So that's what we mean by meeting the patient where they are. And I'm not gonna lie, COVID has placed some restrictions on that, but you know, we're finding ways to work around that and still provide the patient the support whenever they need it. Again, before, when we looked at criteria, we were pretty much open to all patients. Now we're really focused in on patients who have diabetes and it's poorly controlled. Before, our infrastructure was loosely, you know, put together. There was no set timeline. The CHW could see the patient for as long as the patient was interested. Now it's a very tailored 3-part intervention. It lasts no more than 6 months. And evaluation is still a work in progress for us, but we are getting somewhere. So prior to revamping our program, we were only able to really look at our reach, right? How many patients we were touching, how many touch points did we have with them. Now we're coming to a place where we're also looking at patient experience. How satisfied are they with this program when they refer it? How much are they resolving their action plans? And then chronic disease control, looking at outcomes like A1C. Next slide, please. We look at both process and outcome measures. This is a table of what the process measures we are looking at today. So that includes percent of weekly contact, how many of our patients are being contacted by their CHS each week. It is part of the model that at minimum, they make contact with them once a week. We also look at active caseloads, right? How many patients are actively enrolled with CHS, and the target is again 25 to 30 at any given time. We're looking at enrollment rate, graduation rate, percent of short-term goals achieved or resolved, also percent of patients who achieve their long-term goal, and then likelihood to recommend this program to a family or a friend. We want the highest rating possible, either a 9 or a 10. Next slide, please. And then these are the outcome measures that we are looking for. And in the process of collecting now, we are using our EMR system to collect this data, as well as a case management software called a SET. So we go back, we use both systems to collect measures. And as someone who has struggled to define measures of success for this type of program, I was really eager to share these with you because I'm not saying they're the best or the perfect, but it really is helpful to now be at a place where we've whittled it down to these specific process and outcome measures. So of course, we're looking to see reduction in A1C, blood pressure, and or weight. We also want to see that patients are completing their preventative care within 12 months of program enrollment. So, you know, their retinal eye exam, their, you know, whatever they're due for, depending on their age group. Next slide, please. I really do hope that there's a part 2 to this presentation or to this event, because I would really love to come back and share some more hard, concrete outcomes. But like I said, we are still in the process of evaluating that for AltaMed. The model that we base this on has already proven its ROI. Now it's us making sure that it's proven its ROI with AltaMed. And I'd love to be able to come back and share that with you at a later date. But for now, I'll at least end with 2 patient success stories. So our community health specialist out of the Garden Grove clinic, she's been working with a 38-year-old. In January, his A1C was around 13.7. They've been working together. Our CHS connected him to food banks, helped them navigate specialty appointments, provided healthy recipes, helped encourage them to increase their physical activity. And as of June, their A1C is now a 6.8 and considered to be within the controlled range.
Congratulations. That's awesome.
Thank you. And if I can just end that final one, another CHS who's worked with the patient who had an A1C over 14. She worked with him for 6 months, again, provided nutrition information, helped him to get the medications he needed, receive a free glucometer, start a journal. She even helped him secure employment. I think that's what they actually started with. The patient did not have a job. It was stressing him out. And she helped him. She helped him find a job, applied for it. He got the job. And his most recent A1C, late August, was 6.6. So I can tell you that they've helped patients secure jobs. They've helped patients complete a restraining order against an abusive partner, all kinds of things. It all comes down to what the patient really wants to tackle first. Thank you for your time.
Thank you.
That was really amazing. Really appreciate it.
Yeah, that was, and I realize, this is Dr. Zare, I realize it's taken quite a lot of effort and time to get that program to where it is now. And so we certainly look forward to your future presentations to tell us how you're doing. So we'd like to move on now to another example of integrating CHWs into the healthcare environment. We're going to look at the top 10 Medicaid plans in Southern California. And we have 2 speakers for this. First, I'd like to introduce Catherine Knox, who is currently Clinical Director of Point of Service Care Management for the Inland Empire Health Plan. She's in charge of the Model 2 Health Home Program care teams. And her robust nursing experience has really spanned everything from acute care to public care to managed care, and I'm sure quite a few in between. And in addition, she brings an international flavor to the conversation as well, with experience in New Zealand, Australia, and Great Britain. And sometimes some great insights can be had from looking at the way other countries even provide their health care. And to show that she's a true diplomat, she also has straddled USC and UCLA. So champion there, Catherine, to be able to do that in this LA environment. We'll see later at football season. And our second speaker is going to be Dr. Lily Lee, who's the director of the Promotores Academy at San Manuel Gateway College, an assistant research professor at Loma Linda. She's got an extensive background in the community health arena and the Promotores model for quite a few years. And as we've heard today, there's a lot of interesting and I think very impactful issues coming out of using this program. So I won't belabor anymore, but thank you both for sharing and your experience here. And Catherine, were you going to go first?
Yes, I am.
Okay, you're up.
Great. Everyone can hear me?
Yes.
Great. Wonderful. I may just have to put my little dog out the door. He's starting this moment to take a little growl. Excuse me 1 minute. Out she goes.
It wouldn't be the worst thing we've heard on Zoom.
Well, there is such a thing as Murphy's Law, right?
Oh yeah, Murphy.
But thank you all so much for having us today. We're really excited to join the Right Care California initiative. Clearly, just all the speakers before, I think we are all in 100% unison that the value of having community health workers on your care teams, whatever constitutes your care team, they are such an enormous value add. So it's our pleasure to share our experience using them at IEHP. Next slide, please. So where we really began to use the community health worker in a fully integrated way was with our Health Home program. And I'll just give you a little bit of a background on the Health Home program, and then I'll focus in more on the work the community health worker does on that team. But as many of you know, the Health Home program is a DHS required Medi-Cal benefit that it provides comprehensive, complex care for eligible patients who meet eligibility based on chronic condition and acuity criteria. The Health Homes program was actually legislated way back in 2010 with the Affordable Care Act. So it's been around. California, implemented later than other states, and in the Inland Empire, we went live in January of 2019, where we opened up our community-based care management entity, i.e. care teams, for those folks with physical conditions and substance use disorders. And then later that year, in July of 2019, we opened up our programs for members with severe mental illness. You heard me say that word, community-based care management entity. Always trust the state to give you alphabet soup name. It is essentially a care team. So if I refer to a CBCME, that is our care team. Next slide, please. So essentially in our Health Home program at IEHP, we have a 4-person care team, which consists of an RN care manager, behavioral health care manager, a care coordinator, and a community health worker. And the essential core services that are provided through the Health Home program includes comprehensive care management, care coordination, health promotion, comprehensive transitional care, individual and family support, and referral to community and social support services. Next slide, please. So at IEHP, we have basically divided our Health Home network in over 2 models. The model 1 is by far our biggest network, and this is where care teams are actually embedded in the provider's office. And that means that that provider has enough eligible patients to enroll a panel of 200 Health Home program members, and therefore a dedicated team is required at that healthcare organization to provide care to that panel of 200. The Model 2 care teams, of which I oversee at IEHP, these are for our providers who do not have enough eligible members to constitute having their own dedicated team, but they have enough members that they need a team assigned to that provider to help care for those patients. And so that's how we do our Model 2. Currently, we have 10 Model 2 teams and we have 42 Model 1 teams, a total of 52 care teams. Next slide, please. And as of last week, we have 7,500 patients enrolled in our Health Home program across our Model 1 and our Model 2 network. And on average, a member is enrolled for about 216 days, which is roughly 7.5, 8 months. So that was just to sort of lay the ground for you to understand where our CHWs fit into our complex care program. Next slide, please. And this is where we're now going to transition to more specifically into how the CHWs really support the work of the integrated complex care team and their very critical roles that they perform to really allow the team to be successful in helping the members meet their health outcomes. This is a picture of one of our Model 1 CBCMEs, and this is Carlos escorting one of his patients to see her primary care provider. And I believe after that, he took her to the pharmacy to get her prescriptions filled. Next slide, please. So, as many of the speakers before me have talked about, these are sort of the key roles of community health workers, promotores. Accompaniment is a big one in the fact that a community health worker will actually go with their client, their patient, to either their primary care provider or their specialty care provider, or sometimes it's going with them to get their prescriptions filled, or going with them to the DMV to get their license renewed so they don't keep getting pulled over because their license has expired. Anything that has gotten in the way of the member to really prevent them from having a successful outcome with their healthcare journey and those social determinants of health that so often get in the way of successful health outcomes. Home visitation is huge, and prior to COVID, of course, our CHWs spent 70% of their time out in the field, actually in the members' homes, or visiting patients in the hospital. So very minimal amount of time was spent in the office with the care team. Most of their time was actually out in the community, in the field with their members. Health coaching is a huge role, and I think we've heard the speakers before all talk about the value of having that CHW really explain and interpret what those instructions are about following a diabetic diet or following a 2-gram sodium diet, or all of these things that we as providers tell our patients thinking they've understood. But it really takes that CHW to sit down and say, do you really know what they meant by that? Let's talk about things you can do. Medication review is an enormous function of our community health workers. And I think in many ways a very specialized role. But in our program, our CHWs are trained to actually collect the data, collect the information on what medications the patients are taking, and then they can relay that information to the registered nurse who will actually do a medication reconciliation. So I want to just be very clear that a medication review is not a medication reconciliation. That's important for licensed folks on this call who sometimes RNs, the hairs on the back of their neck stand up when they think that a non-RN is doing any kind of medication reconciliation. They are very different.
10 minutes total, please, to go.
Thank you. The transitions of care, another huge role that our CHWs did, and prior to COVID, a very active part of their day. Helping their members navigate the health system, and again, assessment, gathering data, and bringing that over to the care team. Next slide, please. So in the transitions of care, what was happening, in pre-COVID days was that the CHWs would go to the hospital and they would see their enrolled members who had been admitted to the acute care setting. And they would basically do a TOC assessment while the patient was there in the hospital. They would discuss prior to going with the RN care manager and the behavioral care manager, what do I need to focus on when I visit them in the hospital? And it was really a way to give the care team a heads up about things that might be needed post-discharge: transportation, DME, long-term services and supports, any housing security. That's a big one for us in health homes. Next slide, please. And then following the discharge, once the patient had gone home, the CHW would also go and visit that member two to 3 days after they left the hospital. And they went there to really make sure that the discharge plan had been enacted and was being followed through on, because we all know that one of the biggest causes of 30-day all-cause readmissions is a failed discharge plan. So they work with them just to make sure that the medications that they were prescribed while they were hospitalized, those get relayed to the RN for reconciliation. They assist with scheduling those post-discharge follow-up visits, and they assist with getting a home blood pressure monitor, getting a scale, a weight scale, glucometers if needed. Next slide, please. And this is just some data that we collected for 6 months, and of course, all prior to COVID. But what we were able to demonstrate was that a health home eligible member sitting in a hospital bed, if they received a visit from one of our community health workers and had the program explained to them, they had a 37% average enrollment rate, which is pretty spectacular when you compare that to, on average, about 10 to 15% for telephonic outreach. So again, sort of 3 times as high when they actually see that CHW face-to-face in the hospital. That community health worker can really have influence during that visit. Next slide, please. And I just wanted to show you, we can go through these fairly quickly, but this was our year 1 implementation report that we actually put out and provided to the state. Next slide, please. And what we were actually able to demonstrate in 3 of our outcome measures was that we had a statistically significant decrease between baseline and follow-up measurement between systolic blood pressure, hemoglobin A1C, and a PHQ-9. So you can see that systolic BP went from 156 to 142, hemoglobin A1C was 10.7 to 9.4, and the PHQ-9 went from 16 to 13. Next slide, please. We were also able to show that we actually saw a statistically significant higher rate of PCP visits compared to the control group, meaning that patients were getting connected to their providers and seeing their providers, often likely because a CHW went with them to go to that provider visit. We actually, much to our surprise, we saw a statistically significant decrease in emergency department visits, which I don't think any of us expected, because that is something that you just don't see happen very quickly. It was a very small decrease, but it was statistically significant. Next slide, please. And the total cost, as we would expect, went up because we're seeing an increase in PCP and specialty care visits and also pharmacy costs. So you would expect to see an initial increase in total program cost. Next slide, please. And again, just we had a control group, similar base, but not enrolled in health homes. And we were just able to see that they were not statistically significant, but they were slight decreases in the number of fewer admissions to the acute care setting, the average number of bed days, and urgent care visits. So we're hoping that in our year 2 of this program, we're going to continue to see improvement in those metrics. Next slide, please. CHWs have had a crucial role in COVID-19. We all know that our high-risk patients are more isolated than ever, and they really do need to have that touch and that connection with their healthcare team. So the CHWs can really provide that. They can really provide that consistent outreach, touching in, even though we have said no face-to-face visits in the current environment until we have a safer situation with the vaccine availability. So it's no face-to-face currently, but they're still able to maintain that outreach with doing FaceTime, with doing phone calls, just keeping in touch with the members. They're able to assist them with referrals to food banks, COVID testing sites. And right now we're pushing everyone to get an in-home blood pressure monitor so that the blood pressures can be measured and monitored while patients are, at home. assisting them to schedule their telehealth visits, and really continuing to support our patients that have housing needs, continue to refer to the county coordinated entry systems, referring to our IEHP 3H housing program, and also getting COVID positive patients into Project Room Key, getting them off the street and into a protected environment, especially if they have COVID. Next slide, please. And, you know, because of the work that they do, they really do have a unique training need. We need a highly skilled community health worker workforce. We need a diverse workforce. And we need a blend of that traditional Promotores advocacy and that clinic-based competency. We partnered with San Manuel Gateway College 2 years ago to develop this curriculum. And it has been wildly successful. We have trained over 100 CHWs, and they're all sitting out there in our health home network. And as part of their training, they continue to have continuing education after their 9-week intensive, which keeps them really up to date, finger on the pulse with currently what's happening in the community. And with that, I believe I'm now going to hand this over to Dr. Lily Lee from San Manuel Gateway College.
Thank you, Catherine. Thank you, everyone, for for inviting me to this presentation. I think my presentation is probably going to fill in some of the gaps that you might be wondering. So, how are these community health workers and promotores trained? Next slide, please. There are a lot of different trainings out there that are preparing community health workers for different capacities, and you've heard of a few. The mission of our academy is really to come along the different partners who are integrating community health workers and promotores and strengthen their capacities for workforce. Next slide, please. What we do is our model is really trying to train them in a way that is very comprehensive. Just like, for example, the example I like to use is if you're, expecting to hire a nurse, you expect them to have all the different competencies from nursing school, not just focus on pediatrics or disease condition. So we train our community health workers in a comprehensive curricula so that they can be employed and be able to apply the different skills and competencies in different settings, different disease management situations. So, and we build different components from each other. We build different skills in the foundations, and we have actually incorporated the behavioral health because we have recognized that a lot of the patients that our CHWs are working with do come with a lot of mental health conditions and need additional mental health support. So, and our CHWs themselves need the skills to be able to build additional healthy resiliency to work with this population. And then we focus on the clinic base, which is very strategic based, and you've heard Catherine specify the different strategies like accompaniment, home visitation, etc. Next slide, please. So we train them with a lot of didactic skills lab and practicum. It's very hands-on, it's very practice-driven. We use a lot of case scenarios. We have, obtained scenarios from chaplains who work in different settings. We have received scenarios from medical residents who have worked with us as well. And we actually have our CHWs think through and process the different skills that they will utilize, the different tools that need to come into play, and how they will actually implement that to deliver the different strategies. And we focus a lot on professional development, computer skills, public speaking, because we do recognize that they are working at the highest capacity with highly trained professionals in clinical, in the vertical system of the healthcare system. So we want them to be prepared. And we've done research that has shown that a lot of the middle management in the clinical systems, like nurses and social workers who would most likely supervise community health workers directly, they are asking for higher capacities from the professional and computer skills side as well. Next slide, please. So as you can see here in this diagram, our training approach is to really help the CHWs understand that they are not trained clinicians, but they are working very closely with clinicians to be able to help a patient manage their care and achieve their best health outcome and quality of life. So the areas that you've heard in other earlier presentations is social determinants of health. So how do we do that? Next slide, please. We have them work a lot in groups to bring what they already have from the community. As you know, you want CHWs recruited from the community, who understands the community and who will not lose the essence of the community. So we, get them into groups, have them get together, understand what they know, and then we send them out in the community to assess the community, to learn how to gather data systematically in order to learn how to analyze what the deep root causes are and come up with potential solutions that they may want to present to their organization. Next slide, please. As you can see, these are some pictures of the skills lab. We do quite a bit of role play. On the top left, you'll see a physician resident who worked with us, playing his role as a resident, working with the CHW. We bring dolls, we bring, scrubs, whatever we need to really bring a physical context to the scenarios that we are role playing. Next slide, please. Now you may wonder, how do we do that in the time of COVID? Well, we were very creative in utilizing different platforms. We use Canvas, we use Zoom, we use Remind.com, we use different resources to train the students. We use a lot of the breakout rooms, and I know we're gonna go into breakout ourselves. And I wanna encourage you to ask me more questions during the breakout session because I know we're out of time. And we actually have them discuss how they would do it and bring their insight into the different scenarios and actually exercise the different strategies. Next slide, please. So I did mention about the practicum, where they are required to go out in the community to do additional research to try to understand what are the community needs from the perspective of the key stakeholders. And they could be leaders in the community, different organizational leaders, or could be community members as well. We've had CHWs go and speak with homeless in different homeless shelters as well. And they put together a presentation. So we're promoting computer skills, presentation, how to put together a SMART goal, how to put a behavior change plan, how to utilize motivational interviewing skills and harm reduction skills, and how do you put that in a plan that you are going to propose to your organization to make it more of an intentional use of the skills to meet the needs of the population. Next slide, please. And in addition to training CHWs, what we have found is that supervisors themselves sometimes are afraid of or don't know how to train or supervise community health workers, what metrics to use, how to create workflows and flow charts for them. So we do organizational readiness trainings, and we invite not only the supervisors, but everybody and anybody who's going to be directly interacting with the CHWs in their team. And we talk about the different roles, the different best practices, lessons learned, systems, processes that needs to happen, how to evaluate and monitor CHW performance, and different policies, latest policies that are happening in our local state. Next slide, please. And just like all of us in our professional careers, CHWs also, we do believe that they need continuing education. And IHP has done a wonderful job in sponsoring all the continuing education for community health workers. And we dive a little deeper into the different strategies. We're very much in tune with what's really happening in the field. We have very close conversations with IHP and the different health plans through the health coaches as well. Practice coaches, to understand what's really happening. And we dive deeper into the different strategies, the different skills that needs to be refined, fine-tuned. And we talk about disease management. We have recently done ACE on the role of a CHW in hypertension management. How do you interact and work with nurses, physicians, pharmacists on medication review? Again, just like Catherine said, they don't do medication reconciliation, but they can certainly complement those needs doing medication review. A lot of behavioral health with COVID, and we know that a lot of the funding streams are focusing a lot more on behavioral health needs of the population. So we focus on resiliency, trauma-informed care, emotional intelligence, and more. Next slide, please.
Dr. Lee, I'm going to have to ask you to wrap it up in the next 2 minutes, please.
Is
Unfortunately.
it? No problem, Dr. Brooks. This is my last slide. So you may be wondering, how do we ensure that our students are accomplishing their student learning outcomes? You can see on the right side, this is a picture of the Bloom's taxonomy. We know from at the bottom is just knowledge acquisition. At the very top is more creation and just higher level critical thinking. So we really push our students to do the higher level critical thinking, to look at a case and to analyze and learn to prioritize what is the priority for the patient. But how do you do patient-centered care when you're working with multiple clinicians who are asking for different care plans, behavioral health, medication management from, and different specialists. So CHWs are really working through those cases from the training. So you can see a couple of quotes here, and I'll read one is, I have the conversations with my members with more confidence and know what to look for in our conversation to assist. And this was in a case of hypertension management. So in a nutshell, our training, the way we've partnered with IHP is that we have worked very closely to come alongside of the CHWs and the complex care team to provide a training to support the workforce capacity so that the CHWs can be utilized at their maximum competencies. I believe that's the last slide. Next slide, please. Thank you. And I'll be available during the breakout rooms or by email for more questions. Thank you so much.
Thank you very much, Dr. Lee, and to all the presenters. There was a wealth of information that was provided to us, and I believe that a lot of it may not have been well known to those of us that are not as well versed in the CHW program. So what we're going to do now is we're going to move on right into the breakout sessions. There were a number of questions presented in the chat box, and I believe that many of them can be answered within the context of the breakout session. So we will ask you to discuss in the private, if you will, breakout session, one thing that you learned or heard that you could take back to your organization. What would you need? What would you need to implement that? So I'm going to turn it over to Megan, who will give you the logistics and the technical side of the breakout session. I expect this to be in breakout. We had scheduled 20 minutes. I believe we will do 15, and then we will come back and share strictly 2 minutes. Each group will have a leader, and that leader will present for 2 minutes what was discussed in your specific breakout session.
Okay, so we are going to head into our breakout rooms. Once I open up the rooms, a box will pop up on your screen that will ask you to accept the breakout room. Please press that box to enter the breakout room. There will be a couple seconds, but once you're in the breakout room, normal audio and video will be available to everyone. There will be a timer that is displayed on the upper right-hand corner of the Zoom screen, so you will be aware of how much time you have left. And once that time is up, there will be a brief 15-second grace period that will occur, and a box will pop up saying you have 15 seconds to wrap up, and then you will be automatically returned to the main meeting. If you have any questions, there is an Ask for Help button that will be on the bottom of your screen once you're in the breakout room, and if you press that, I will come to your rescue.
Thank you, Megan.
There are a few of you still in the main session. Please accept the request to go into the breakout room.
Well, I'll just pipe up and say I thought that was wildly successful, and we're going to have to learn more about it and do that more often.
From my personal perspective, I agree. Megan, are you there?
I am.
How many breakout sessions did we have?
We had 8 groups.
Okay, so I'm going to ask, starting with anyone. Everyone said breakout room 1, right? So I'm going to start with anyone. You have exactly 2 minutes. That's going to take us to, we were planning at 2:35, and we will end approximately 2:35. So someone give me their 2 minutes. Go. I got a timer.
So I think we might just go in order of the groups listed.
Well, there was order?
Yes,
Okay.
you are numbered. Oliver, you are group number 1.
Oh, okay. I said mine said group 1. Very good. So I already burned up 20 seconds. So as our session was excellent, and it was interesting because the people came from their own personal perspective, which is the purpose of a breakout room. So there was one who was worked in claims, and her statement was she was impressed at actually CHW's work, and not that she didn't know that, but it was clearly made evident, and that she feels that they may need to be actual part of the patient visit. They need to maybe even come in with the patient for better communication. There was someone else who worked with the LA County Chronic Disease Program, and they felt that the nugget they got was that the CHW reported not to a clinical person, but to someone non-clinical who would be more available, that would be more availability. One of our people stated that the goal is to get different stakeholders and have different perspectives together so they can hear all of this and then ultimately get past the obstacles, which are always there. We had someone who is just working now, and they want to be a CHW. So they liked Dr. Lily Lee's presentation of how to be a CHW and how the fact that it was, there was a standardized, here, go do this course. And then someone stated the fact that they like the fact that the approach should be whole person care from the beginning. The concept of the health homes program and whole person care, that you should start with that, not I'm a 37-year-old male with diabetes and hypertension. Start with I am, Mabel Martinez, who lives in this zip code and has this particular lifestyle. Now let's start talking. So I felt that we got a lot of different things, and it was excellent. So I'm going to move on to group session number 2.
Hi, this is Dr. Zayer. Can you hear me?
Yes.
Okay, thank you. Yeah, we had an interesting discussion too. I think the things that were brought out as the learning episodes were that, as one of the speakers mentioned, it's simple but not easy. That when you look at the individual aspects of the role and the training and what it encompasses, it looks pretty simple and one that everyone would buy into, but it's actually not as easy to go down that path quickly. Also, that the social determinants of health are very, very important to any kind of return on investment, whether it's from the community perspective, the patient perspective, or the plan, or the medical group. That was made pretty relevant. Getting buy-in from whomever you're going to get buy-in from has to do often with the monetary aspect. That there is financial impact, but there is probably not only a financial gain for the organization, but again for the community as well. That there are aspects that that we as physician providers, pharmacist providers, etc., we don't get into patients' homes. We may not always have time to talk about the family. We may not have time or interest or education into talking specifically about nutritional elements. So that using the whole program to get buy-in from whatever organization we're in, that we can't provide as adequately as we'd like to.
Thank you. Thank you, Carol. And Lily put in the chat box real quickly, you can get CEUs or CEs, educational credits from her program. And she said they're free. Excellent. Breakout session Group 3.
I think that was me, even though I'm listed under 5. This is Don. Very interesting. Most everybody in our group actually were community health workers or working in that area. As a matter of fact, we had one person calling in from a mobile clinic during the presentation. I think some of the learnings that they had were the importance of looking at hiring more CHWs actually coming from the community. That it's important that they come from the community and to be able to understand that and work well within it. I think one of the other things that personally I learned was the structure around some of this and how does this integrate with the existing medical groups or medical systems within a community, as each community is going to vary. So that I think were some of the key learnings that we had taking back, but I was sort of preaching to the choir. These are people working in the area. So it was an interesting discussion.
Does Western Health Advantage use CHWs?
Well, you know, we are a completely delegated model since we're provider sponsored to our medical groups. And I do know some of our groups have. Woodland Healthcare is very integrated in with their community. I don't know exactly how the others do it, but all case management is even delegated to our medical groups by us. So that's where the action happens, where it's closer to the practicing physician.
Thank you. Thank you, Don. Breakout Group 4.
Hi, for Group 4, I was with Dr. Joe Skye and Dr. Lily Lee and others. And so we had a greater opportunity to ask Dr. Lee some questions, which included how to actually identify community health workers or advocates to get them in for jobs. And so Dr. Lee described a bit more about job fair opportunities and just to be very clear about the job description. She's also clarified in the general chat that although some continuing education units are available, they will be advertised if they are free or if there's a charge. So certainly follow up with Dr. Lee on any more questions. We also got great input from several community health advocates that shared what they're doing in the Monterey and Tahoe forest regions of the state. And so just hearing, you know, sort of on the ground, how it is difficult to reach, like you might be able to reach a certain population by social media, but there's going to be another maybe harder to reach, possibly undocumented group. And so the, you know, critical way of trying to reach them is through building rapport, trust, getting word of mouth, which may take time. So in terms of budgeting and allocating that. But certainly a wealth of information. I think we'd invite others to continue to share more even after this meeting, if you might. Thank you. Anything else, Dr. Skye?
Well, I think the other thing that Dr. Lee was able to point out is that the people who are able to get this training and enter this workforce are getting jobs that pay well for the communities they're in, and they're getting benefits, and they can be part of the community and be rewarded appropriately doing this really good work.
Great point. Thank you.
Right. Thank you. All right. Breakout Room 5.
Hattie, you want me to report? Okay. We had a very robust discussion, a lot of great experience in our group. Many things came out of it. There was clearly an understanding of the benefit of CHW programs for high-risk patients. Many were impressed with their integration with FQHCs, with FQHC leadership. Highly impressed with Dr. Lee's training program at Loma Linda, the curriculum, and the way that program was able to integrate with public health and quality improvement. And as was just mentioned by Dr. Skye, I was just thinking that there could be a great alignment between pharmacy technicians and maybe some kind of merged role with community health workers, because similarly, we're training them to be clinical and they're having very robust careers, very enjoyable careers, doing something directly patient care related. For needs, no surprise, funding payment models to be developed. There was some general questions about, is there a roadmap for how health plans can start working with community health workers and align CHWs with QI and needs? And I'm going to actually ask Joan Werblund to speak a little bit about sort of her parting comment, which was, I thought, fantastic about education. Joan, you want to chime in for a second? If you're available. Okay, she's not available. She started to talk about the importance.
I'm trying. Okay, I finally got
there you go.
unmuted.
Go
I
ahead,
couldn't
please.
get it to unmute me. And you wanted me to speak
You
about
started to talk about the importance of educating
the
the
community.
Yes.
I think one of the biggest things to take away today of all the programs I'm involved in is to educate the community, all aspects, the professional as well as the citizens in the community, as to just what is a community health worker. They seem to view it as some kind of a psychosocial worker who, you know, does nobody knows what. The role is clearly not understood. And from my experience with several grants that I've had, they're just, you know, irreplaceable. Community health workers are just so important. But I think we need to do a better job of educating what this is, what this role is.
Could you talk about the high school program that you've helped establish in Sacramento?
We have it's at Valley High School. It's a high school health academy, and it's the only certified one in the United States at this point. And we do follow the Penn curriculum and the Loma Linda. It's the same curriculum. But this program is a 4-year program. Students can enroll in 9th grade, although now they're able to take some prerequisite classes in 7th and 8th grade. And it is superimposed integrated with their normal high school curriculum. And we have now attached it to 2 years at City College, where the students are eligible to take classes there that are appropriate for them, and they get college credit. And Sac State is now working with us. It's a very vigorous program, and the students do mentoring at Kaiser Hospital. They do mentoring at local freestanding clinics. They participate very robustly with HealthNet and their community health fairs and programs. So it's a very good program that I am sorry to say most people don't know exists.
I think it's a beautiful model, and I would love to encourage all of California to make that the norm, because those kids who want to get involved in healthcare would then have a path to stay really engaged in that early passion.
Well, it really is, and it emphasizes you don't have to be a nurse or a doctor to be interested in healthcare and to be out in the community. And that's the thing. And we've had a couple graduates go on to be medical students at UCD and several into nursing, but a lot of them have gone on to be x-ray techs, and whatever their field of interest is, they now have a career. Great. So I think it's really important that we encourage our young people.
All right.
Joan.
Thank you. Yes. Breakout room 6.
Hello, this is Maria Lemus, and I just want to reiterate what John was saying. I think it's really important to inform and advise in the community. They're already leaders. They just, there's just nomenclature they're not familiar with oftentimes. In ours, we did talk about, well, a little bit more about combining the community principles and the clinical discussion and kind of the integration of that, which I think follows on the previous workshop's discussion. How is it that we can inform that there are already leaders out there and that they're capable of entering? There are some obstacles that we have to look at when entering any kind of training, such as required educational level, capacity for English speaking, and transportation and costs. So there are some things that continue to be barriers in some of the instructional places. And so our discussion was really, how is it that we can bring community forward so that they're engaged more in this opportunity? And that's what our discussion centered around.
Thank you. Breakout room 7.
Jessica, I'll go ahead and start. And if I miss anything, please chime in. Does that sound good? Good. Our group discussion focused in on the pharmacist, and we talked a lot about the collaboration between the pharmacist and the community health worker, and the concept of the pharmacist being a community health worker. We also talked about the distinction between medication review and medication reconciliation. But really, I think the key message that I heard during our conversation was the cross-functional collaboration between the various workers and their scope of practice. The other thing when we got to the second question was, how can we bring it home and maybe implement it within our organization? One of our participants talked about starting slow and expanding as results are demonstrated. Jessica, do you have anything else to add?
No, that's it. You got it. Thank you.
All right, thank you. And then breakout room 8.
You're muted, Bill. Please unmute.
Did we miss group 7?
We just heard from group 7. That was Dr.
Breakout group 8.
Cindy
I didn't hear anyone speak.
So we're with Bill Baumer now.
All right. Hi, this is Bill Baumer. Breakout room 8 was the last, but it was the most robust of the breakout groups, I would have to say. We had a great experience, primarily because we had individuals who were newly trained in community health workers. Or were experienced or were teachers in the program. So we had a broad spectrum of individuals across that. And we had a significant conversation and every one of our members contributed. So I want to thank them. The important points are that we went over is there is ROI inequity, meaning currently the ROI bar is much higher for community health programs and workers than it is for other established programs. So we think that the ROI shouldn't be unfairly shoved to the community healthcare worker program, but should be across the board for all of healthcare systems. The other thing was in both dealing with patients, there should be setting up of goals. That's very important. That came out in the program, as well as in training, so that trainees learn what they need for achieving their goals and their graduation. The next thing was that bridging the gap between medicine and social is vitally important, and we have to recognize that we have to bridge the gap between our medical approach to these patients and their social problems that is there. And lastly, I would say that our group was, I think I was very encouraged that our group has been willing to take the extra step. So we talk about bridging the gap, advocacy for our individual patients and the patient groups that are there. But our group took the extra step of going farther for advocacy and jumping on community boards and other government organizations and programs so that they could have even more influence. So it may be good to be advocates for our patients, getting them all the support they need, but we need to go one step further. We need to get out into the public and the community and get some of these benefits across the board for individuals, because we do have a significant problem of social justice to approach. And the only way to approach that efficiently is to get beyond individuals and get out into the community to advocate for social justice for all of our patients.
Bill, had you incorporated the community health worker into that very innovative clinic that you were running with pharmacists from UC Davis?
So the definition of community healthcare worker, we did work with Maria actually to see if we could get something along those lines. But because of finances, what we did was we then hired and trained our own individuals to do that. And we found lower costs by taking recent students or graduates who needed a job, and we went to them and we were able to train them to bring them into our high-risk clinic for that. So I think the difficulty was we originally worked with Maria to see if we could get contracts. The cost of that was higher than that we had funding for. So we went out and went one step farther to actually recruit individuals that we then individually trained for that. So yes and yes for that question.
Well, interestingly, right there, your former UC Davis nurse, Joan Warblin, has a community health worker training program at high school. So maybe those things can be linked up in the next iteration. I have one more question for Dr. Oliver Brooks, who's done a great job facilitating this session today. Thank you, Dr. Brooks.
Thank you, Hattie.
Could you mention the amazing program that you briefly presented on August 10th when we had Dr. Lawrence Sperling from the Million Hearts program with us, where you're training African-American women to become community health workers for their own families and communities?
A good way to look at it, Hattie, because I hadn't really thought about it that way. So a program in conjunction with American Heart Association, American Medical Association, Association of Black Cardiologists, others, and the NMA, National Medical Association, getting 300,000 Black women to take a pledge to basically control their blood pressure and get their health under control, and ultimately to bring other people along with them. So they call it a squad. So if you take this pledge, then you ask others to take the pledge, and you work together as a group to essentially do self-measurement of blood pressure and get your blood pressure down. So if you want to look at it as they become community health workers, they develop their own community and work with them. So I really like that concept. 300,000 Black women to do that and 75,000 to look at our training videos. So thank you for bringing that up, Hattie.
Well, one thing that I learned in this exchange, putting this together with so many brilliant people, is that community health workers are making about $45,000 a year. That's real money for some communities that are not well employed. So I hope that we will catalyze a lot of interconnectivity as a result of this program. And I really want to thank our operations team, Dr. Cece Wu, Bob Trine, Alyssa Meyer from USC, my team at UC Berkeley, Megan Olson, Jenny Wu, Kathy Yarashevich. And Dr. Ivy has been amazing. It's really been a community effort putting this together, and also just all of our leadership who were acknowledged early on. I wanted to make sure that the operations folks also got due credit. A really amazing program today. And I also want to invite you all to join us on the last Tuesday of this month for a wonderful program that we've put together that will highlight the importance of the work that community health workers do, and all of those who are on the phone who are dedicated to driving down and well managing the trifecta of blood sugar, hypertension, and cholesterol, because it turns out that managing those things well is critically important for COVID-19 outcomes. So it enhances the importance of the community health workers and the integrated team approach in this pandemic emergency that is having a terrible impact in our Black and Brown communities, in particular in California and across the nation. So this model is also going to be somewhat highlighted by Dr. Cindy Jambroni, who you heard from a little while ago, about how her organization took learnings about hypertension management from the Right Care University best practices and created a program called Mind the Gap. and she will be talking at length with her medical director about the collaborative community approach that they have taken to greatly improve their performance in hypertension control. So with that, Dr. Brooks, would you like to wrap up the meeting?
Certainly, I just want to thank the presenters, and I have to say them by name because it's important. Dr. Rishi Manchanda, Maria Lemus, Dr. Jessica Abraham, Dr. Ian Shapiro, Jessica Solaris, Catherine Knox, and Lily Lee. We really appreciate the information. It was rich. We had to sacrifice our Q&A, but we got our ROI on that. We got more. So again, I will thank everyone for your attendance. Thank you for your leadership, Hattie Henley. And we'll see everyone in 2 weeks and 1 hour, okay?
Thanks everybody for all that you're doing to better protect families across the world, and families like mine benefit from all of your great passion. I would not have lost my mother when I was 15 if these sorts of innovative programs might have been in place then to manage hypertension proactively. So, and I especially want to commend Dr. Baumer for having really taken the lead in Sacramento to get all of the health systems to goal for hypertension control. It's been phenomenal to see what's happened under his leadership. Leadership matters, and we love the fact that you are in a leadership role with us now, Dr. Brooks. Thank you.
Thank you.
And thank you, team. Thank you, speakers.
Slides will be on the website, so right here, we're there for you.
Thanks, everyone.
Thank you very much, Oliver, for a great program, as well as all the support staff. Thank you for clearing the smoke on this very important issue. And hopefully the rest of your day is just as clear.
Thank you very much. Pun intended.
Bye, everyone. Nice to meet you all who I had not met before. Thanks for your leadership, everyone.
All right, thank you.
Thank you.
Take care.
All right.
Bye-bye.
Bye.